Hello and welcome. It's Jimmy Kusha. I'm here talking at the 21st Annual Echo Symposium in 2021, virtually again, just like last year. We're going to talk about some basic 3D echo concepts, and we're going to also specifically talk about different maneuvers and manipulations you can do on the data sets of the 3D volumes. Specifically with the Philips Epiq systems, but the general principles apply to every other ultrasound machine. So hopefully this will help enhance your practice and give you a deeper understanding of the world of 3D. And so some basic concepts, limitations, what's going to hold you back from getting a good 3D volume and image, and ultimately, excellent information. Some of the limitations are that you need a good 2D image to achieve a good 3D image, so garbage in, garbage out. So if your 2D images are suffering, and if you're trying to look for a ventricular volume three-dimensionally, and you have to use contrast, currently our software doesn't allow us to do something like that. So, without the good 2D images, you won't be able to get the good 3D images. Another limitation is ECG signal. So if your machine, for whatever reason, doesn't have an EKG on it, the program doesn't allow for us to acquire any volumes or images without an EKG signal. Holding the breath if the patient's very lungy, that can also affect the volumes. Because you're doing volumes instead of just 2D, sometimes it takes a little bit longer to process and capture it. So having them hold their breath, that helps increase the quality of the image. Sector size, the smaller the sector, the faster your frame rate is, so you can get better pictures and more data, higher quality data. So that's always a good thing. Color Doppler. Whenever we use the color Doppler with the 3D, that's also additional information that the machine's trying to figure out volumetrically. So that also helps. Well, it doesn't help. It slows down your frame rate. So you might be going from 25 hertz, 25 frames per second, down to 12 or 15, sometimes 9. And then you can use the different things like the sector size and a few other tricks to boost that up and get to an acceptable frame rate. Another limitation is stitch artifact. So if you are taking multiple volumes and the computer's trying to put them together, you get these artifacts where the volume is kind of out of sync and out of time with itself. So usually to combat that, we'll just do one beat acquisitions, or like HVR for the color, which is also sort of like a one beat acquisition. Now if you do choose to use 4 beats or 6 beats to make up your volume, the quality will be better if your heart rate's going slow and your machine can process it fast enough. And just a few things that we can use to tune up the pictures is like the frame rate, which we talked about, reducing your depth, tightening up your lateral and elevation window sector with HVR for using color versus just the one beat loop, which also goes into loop settings, which is also we choose typically one beat loop versus the multiple beat loop. So some different maneuvers and manipulations. This applies to especially the mitral valve, but we can also use the same stuff on the aortic valve, and to a degree the tricuspid valve with typically a little bit less success. So we'll use the z-axis to get the en face view. So with this is also called the surgeon's view, at least in relative terms to the mitral valve. So we'll bring basically, so we see it's almost like a smiley face. So we'll have the lateral on the left side and the posterior or medial on the right side of the screen. And then that way we can look at the different scalps and see the different like A1, A2, A3, and how P1, P2, and P3, how they're acting, if they're flail, if there's a blown segment, or if there's calcium buildup. Gives us a good idea of just how the mitral valve is mechanically doing. And that goes to rotate to the proper reference point. And so with the en face view, typically we'll have the aortic valve. If the screen was the face of a clock, we would put between 12 and 2, usually about 1, to get that en face view. And the good thing is, since we do this very consistently, you can sort of compare apples to apples. And it's just good to have a standard, much like how the IAC has different standards for echoes. We do this just to ensure, high quality imaging. And we also use our cropping. So there's several ways to crop. They have the X, Y, and Z axis. So the machine has the ability to sort of light up a plane and go through the X, Y, and Z axis. So X would be up and down, Y is left and right, and the Z axis is sort of like front of the screen to the back of the screen. So this helps you able to crop down some of the volume and sort of get to the pictures that you want. We also use a cropping plane, so this is sort of like a free flow cropping plane. This is one we typically use. We have, there's 2 variations on that. There's the one with the plane, so it looks purple, so it kind of gives you an idea of sort of like a frame of reference to where you're changing the volume and kind of cropping different information away. And then we also have what's called a face view, which is like an invisible plane. So we just operate changing the plane to cut away and bring back the different information. And then we have other techniques, so sort of like true view, that it helps us see different structures and outlines, sometimes a lot easier than we would with just a traditional 3D blue and yellow type view. So it actually adds quite a bit of enhancement, and any information you get that's accurate just helps, better information, and helps make better decisions. So that's another tool in our toolbox that helps us get that to the finish line where we give a good information to the doctor. So transthoracic echo, it's not as clear as it is on 3D, just because you're going through the chest wall and bone and tissues and the lungs. So obviously it's a disadvantage compared to TEE. There are still a few things that you can do to help maximize that, and sometimes you get lucky and you can actually get a pretty decent usable picture. Where I've used it myself personally is with the mitral valve, so you can sometimes get some good mitral valve anatomy just using the different techniques. That you have to work a little bit harder at it than you would with the TEE, but it is possible. And then another technique I've used is in pediatrics, looking for the ascending aorta, which obviously could be carried over to adults as well, is getting a true ascending aorta sort of like a transverse picture. So, you know, we sort of see the circle, which, as we've, you know, come to find out, it's really not a circle. A lot of times it's like an oval, but with 2D, it's hard to see that. But with the 3D, we're able to manipulate the information so we can actually get the true width of, say, like a dilating ascending aorta. And we have T3D, so this is very clean and can be very clinically useful. You can get excellent imaging that can kind of really tell the story that you might not get with other modalities, especially with mitral valve regurgitation. We can see, you know, if it's just one leaflet or if it's multiple leaflets. So when you know that information when it comes to mitral regurgitation, just how bad the valve is beat up, then that helps them plan their surgery accordingly to, hey, can we put like a mitral ring in this and fix this? Or do we need to put, is this not possible? And we have to go with a surgical approach and do, a full mitral valve replacement. We also can look at our left atrial appendage. So this is good, especially for the watchman, so we can get an accurate assessment of the type of appendage and how deep it is and how wide it is to make sure that it fits within the parameters of the devices we have. And then it's also very helpful looking for a clot in left atrial appendage. So if you're doing like a TE right before a cardioversion, this will help make sure you don't have a thrombus in there, where that can obviously cause trouble. And we've also used it in PFOs and ASD patients, so it's good to assess for the PFO and ASD from transthoracic. We've also done this with a 3D ICE. That's also another option that can be used. And we don't do this so much anymore. We did quite a bit back in 7 or 8 years ago when we were first starting the program, but you can also do the aortic root sizing for the TAVR. Basically, we've come to find that the CT is pretty darn accurate, so they rely on that heavily. Every now and then, if there's something the CT can't see, they will ask us to do that, but as a general rule, we don't do that nearly as much as we used to. So next up, we will show some live action picture, some video of sort of at first our transthoracic attempts at some 3D stuff, and then we'll move on from there. Once we get to a few basic principles, we'll move on to the 3D TE and look at those images and kind of manipulate them and kind of show different things that we can do to help give them some good answers. All right, first we're going to look at X-plane. So that's where we have our X-plane button, so we can see our screen there. Hit X-plane, and wherever we put the line through, we get a 90-degree version of it over here. So if this model is our X-plane, so we have our longitudinal here, and then we get a circular one here. So we can go up on our aortic valve. We'll zoom up so you can see both planes, 90-degree difference of any anatomic features that we use. So this is helpful with the transthoracic for doing like the aortic valve. You can also do the mitral valve. So here we have the apical. So we can use our X-plane here also. So we get essentially what's a 4-chamber and a 2-chamber. And we just use X-plane to activate, and then we hit X-plane again to get out of it, or we can also use the 2D and get out of there. And just as before with the parasternals, you can also move your X-plane and get your information, your split there with different structures as needed. All right. So next up is 3D zoom. So we just get our picture here. So we'll do it on our aortic valve here. So 3D zoom, just like I explained, you have two different planes. If your structure isn't fitting inside your box here, so our aorta is not quite fitting in there, we have our elevation width. So we can turn it clockwise to make it wider, or as you make it wider, it kind of slows the frame rate, so you can also kind of drop it back down there. And once you got it properly situated, you can hit 3D zoom again. You know what, this looks like garbage. We'll go with the mitral valve. All right, so back to next up, live 3D. So we just had our button here. And you can see our section. So 90 degrees this way, about 50 degrees this way, but we can change that. We can use our elevation width, which is just the second button over to the left from the rightmost here, so we can make it thinner and our frame rate increases. Or if we make it thicker, you can see our frame rate jump down to 30. So just depending on what you're needing, you can make it faster, and generally speaking, the higher the frame rate, the better quality the pictures. And just to get out of that, we can just hit 3D or 2D. And also with our lateral size, if we're too wide here, we can shrink that down. And it also really increases our frame. That's 100 frames per second. So that's really good. We can just magnify on that just using our zoom button. And we can unzoom it, hit 2D, and then we're back to our regular 2D. And cut. You were on, yeah? Okay. So next is heart model. So this helps us find like the volume of the heart to help calculate the ejection fraction. You can also calculate the ejection fraction of the left atrium. So to do that, we just hit our heart model button here. And as you can see, just like X-plane, we have gives us two different planes. We can see in our 3D, we're kind of overgained here. So to kind of combat that, we can come out, drop our near field gains kind of uncomfortably low, hit our heart model again. And then it looks more appropriate. So we can acquire that. Here we go. When we'll acquire that, that's prettier there. So we'll hit 2D, and to get into this, we'll hit our model with our pointer, double click, and now we have our two segments with our volumetric set there. And we'll hit dynamic heart model, which is the software we have with this machine. And then it will help calculate the volume using voxels instead of pixels. And also use a speckle tracking. And the nice thing is it's fairly comparable with string, sometimes even a little bit better. And it's computing. And now we can see our 3 different planes. This is our volume. We have like a 3D representation of our LA volume and our left ventricular volume. And it also gives us an ejection fraction, our left atrial size and how much it's ejecting, and the heart rate. So it gives us a lot of good information really quickly. Alright, so you can see we have our mitral valve, so we can do a few more adjustments to kind of look at things. So we have our 3D vision, we can use depth of color. So this is kind of what the standard is, that we usually do the 3D, but we can do a few more things to show different things. So we'll change from our depth, and we'll change to, we can get a true view, which gives us sort of a tissue version of what the machine thinks the mitral valve looks like. So we can see this is kind of our posterior leaflet, our anterior leaflet, our aorta would be here. And then in addition to that, we also have true view depth, which helps show borders especially a lot better. So what we do is we'll hit our touch view button here, and then on our screen we'll have a replica of what we see here. We'll also see on our screen. And then to activate the light depth, we push, we just hit our screen here, and it will also show up here. And then we can drop the light, so when we go clockwise it goes even further down, so now it's down into the ventricle. And then as we come up, it comes further up, and then you can even go higher above it, so we can kind of even look into the mitral valve. So if we're looking at like the mitral valve annulus, trying to find an accurate like area, we can kind of scroll back and see up here. So you can see the annulus fairly clearly if, for example, we had to measure that, just kind of following the arrow or the finger, just kind of, you know, this segment here, where with the regular 3D depth color, it's not as clear. So it's just another tool in the toolbox to help you make better measurements and get better decisions and better outcomes. And cut. So here we can see a good representation of a kind of a frozen image of our 3D TE. So we are at the en-face view. We have our anterior leaflet and posterior leaflet. We can see our left corner, right corner, non-corner sinus. We can see the aorta is up at the 12 o'clock position. So this is, as I've said before, the surgeon's view. So with this, we get an excellent look at the anterior leaflets, the A1, A2, A3, and then the P1, P2, P3. So we'll be able to see, you know, if it's MR from like a structural standpoint, meaning there's a blown cord or degeneration of anterior leaflet or the posterior leaflets, or if there's like a blown cord, versus the functional MR, which is caused by like a dilated ventricle and atria where the cusps just separate from each other, and there's nothing actually physically wrong with the valve, but the annulus and the rest of the heart's so stretched out that the leaflets can't co-opt and keep the, you know, the blood from the left ventricle going into the left atrium. So that's kind of the difference between the functional and structural MR. So MR is a physical problem versus functional, which is also a physical problem, but is the dilation from the ventricle. And here's a website where we got that awesome picture from. Alright, so here we have a 3D mitral valve. We've already done our slicing and dicing, so we have a good on FOSS view. So just to refresh your memory, we have our anterior, posterior, A1, A2, A3, P1, P2, P3, our lateral and medial. And if we freeze it, we can see we do have some gaps between the commissures. And when we do our color Doppler, our 3D color, so we can see all the mitral regurgitation. And the nice thing is with 3D, we can look at it from different angles and see things that normally you would kind of miss with the 2D, or at least be more of a challenge to see. And probably the biggest thing here is that there's multiple regurgitant orifices. So we have one here kind of cutting across, one big one coming across here, just sort of straight coming at us, and then we have a third one coming this way. So that wouldn't be very clear with just 2D, but with this it's very clear. So we can also get sort of like a side view here, and then we can crop that, shave it down, then you get a real good idea of the of just how big the regurgitation is and how far it goes across the valve. And you can also get a sort of a vena contracta, fairly decent measurement of that. And then we can kind of just spin it around this way. So this is from the ventricular side, and we can also do sort of the same thing. So we'll use the plane, we'll crop in. So we'll cut into it. Okay, we've gone too far, so we'll back it up. So you can get an idea of sort of the regurgitant orifice of the mitral valve. Usually bigger than 0.4 is more than severe, and that's definitely more than severe. So we can also use our true view, and this also helps you know, if we're just looking to see where the commissure's meeting at, where there's gaps at, and this shows us, you know, several spots across really just the whole valve where there's lack of coaptation. So that's kind of why we have all that regurgitation is basically goes across the whole commissure of A2, P2, and P3. And go a little fast here. And then, you know, to help them size the valve, we can get our area. So using the true view, we can get that border very clearly. So if we were back here, we can go 3D, touch view, true view depth, hit our light, and then we can adjust our light depth, and then we can recreate kind of like what we saw there. And we can just move our, manipulate the data however we want, and well, we knocked it out because it's a recorded picture, but basically we could get cine that and get to our spot right there. So that's how you would get that border defined.